Welcome to NHS Borders. I am Callum Campbell, the Chief Executive of the Health Board. NHS Borders is an integrated health board in the southeast of Scotland. We cover a geographical area of around 18,000 square miles. We have a population of around 113,000 and approximately 4,000 employees. As an integrated health board, we provide a full range of primary care services, from GPs, community nurses to allied health professionals. We also have 4 community hospitals. We provide a full range of secondary care services from the Borders General Hospital, surgery, medicine, diagnostics, paediatrics and maternity. This video is just about one team within the Health Board, the Critical Care Outreach Team.
Our challenge within the Borders General was the early identification of the deteriorating patient. And to achieve this, we had to change our systems and processes. And we introduced and developed an early warning chart that would help us do this. Using our chart, abnormal observations are highlighted by yellow boxes. And when 2 or more yellow boxes are triggered, this triggers a call to the Critical Care Outreach Team, who will come and assess the patient.
The Critical Care Outreach Team come down to the emergency department to assist with the care of our critically ill patients. We see many patients who are critically unwell. The role of the emergency department is to recognise the sick and deteriorating patient and highlight them to the Critical Care Outreach Team as soon as possible. The team offer an area of expertise in a timely fashion, and this ensures that timely treatment is given where appropriate. It gives good continuity of care for the patients and their families and relatives, and this is carried forward when the patient is transferred to the ward area.
So as a consultant working in the intensive care ward, the main benefits I get from the outreach service are that we get an improved quality and timeliness of referral of patients requiring ITU treatment. That means that they are less physiologically deranged when they arrive with us. They are susceptible or less susceptible to critical care treatment complications, and consequently their treatment hopefully will be smoother and have a shorter length of stay in the intensive care ward.
All calls to the outreach team are calls for help, and we treat it as that. We never judge the referrals. We'll see everybody that we're asked to see, and we encourage the nursing staff and all other allied health professionals to call us if they're at all concerned about any patients. This is the monitoring chart we use in the Borders General Hospital. The nurses take the observation and pop them on the top of the chart as normal. They then transpose them into this grid here. If 2 yellow boxes are hit, they contact the Critical Care Outreach Team. If there's a suspicion of infection, then the sepsis 6 is triggered, and a prompt is at the bottom of the chart. Hello. It's Carly, is it?
Yes.
Hello, my name's Hazel. I'm a nurse on what we call the outreach team. They've asked me to see you today just because your temperature's a bit high and you're just feeling generally awful.
Yeah, and I have a pain in my side here and feel pretty awful and quite hot.
Okay. So kind of what I'd like to do is just do a set of observations on you, if that's okay.
Yes.
Now Carl, if you'd just like to listen to your chest, if that's okay.
Yes.
Now just listen to the front to start with. Just take nice easy breaths for me.
What critical care outreach means to me is that patients who are sick get referred to me sooner. The sooner the patients are referred to me, the sooner I can do something about that with organ support. If we get patients who are earlier in their disease process, it's more likely that we can do something about that and make those patients better quicker.
A lot of evidence has come and gone over the past 12 years in intensive care medicine. One of the most enduring pieces of work is by Manny Rivers, and it describes about achieving our resuscitation goals within 6 hours improves patients' outcome. A recent presentation at in the Society of Critical Care Medicine's 42nd meeting suggested that 3-hour goals were better for patients than 6-hour goals. I believe that the only way to achieve these goals is with an effective outreach team.
When patients recover from their critical illness, they're discharged back to the ward. What critical care outreach means to me is that that patient stays on the intensive care radar. Sometimes patients go to the ward and then deteriorate again. This can be very difficult. If that patient deteriorates to needing organ support again, after they've already had a prolonged period of organ support, managing that can be very difficult. I believe what outreach does is it recognises that problem very quickly, allows us to intervene very quickly, perhaps for a second time, and allow that patient to recover without needing further organ support.
We as nursing staff monitor the patients quite closely, but the outreach team also come in and monitor them, so any deterioration in their condition can be picked up quite quickly and then acted upon appropriately.
And when patients are discharged back to the ward, we maintain a regular communication or a regular dialogue through the outreach service with what's been happening to them subsequent to their discharge.
At the time of my admission to BGH, I probably couldn't tell you anything about my pelvis, never mind what critical care outreach was. What soon became clear, though, was that I was in very safe, caring and understanding hands at the BGH.
I very much appreciated and was grateful for the service because the nurse clearly explained my illness and the pathway to my recovery.
It is the little things that can make all the difference to patients and close family, which is why the structured approach to critical care outreach works so well.
We have illustrated outreach and the systems around it. For me, outreach is about quality assurance. And that assurance is that if there's an unwell patient, they will be recognised in this hospital. And once recognised, the appropriate resources will be brought to that patient to help that patient. For me, outreach saves lives.
I trust that this video and visit has been beneficial in giving you an understanding of the work that Ronnie and the critical care outreach team undertake. The identification of the deteriorating patient is a responsibility for everybody in the organisation. I trust this has been helpful in giving you a guide as to how you might progress within your own organisation.